Welcome to the R.E.A.D.Y program, put on behalf of the City of Auburn, Washington. My name's Dr. Steve Anderson from Multicare Auburn Medical Center and the National Board of Directors of the American College of Emergency Physicians. And I'm here to talk about the problem of mental and behavioral health. It is the #1 cause of calls to 911. And so we're trying to figure out a way to help make our communities ready to deal with this problem, because real emergency aid depends on you. That's what R.E.A.D.Y stands for. It occurred to us a few years back here in Auburn that the #1 cause of death in America was cardiovascular collapse. And we learned that by training people in how to do CPR, we could save lives and make heroes in our community. We learned shortly thereafter that the 8-hour class that helped teach people how to do these life-saving procedures in the streets made us the safest community in the United States to have a cardiovascular collapse and an arrest. And we realized that by doing that, we were one of the safest places in America for that disease process. But as it turned out, as time went on, we discovered that 8 hours was an awful long time to take to teach busy people how to do hands-free CPR. We came up with a 1-hour class to help teach people how to be heroes in that regard. So fast forward to 2017. It occurred to us here in Auburn that almost 60% of our 911 calls to police, to fire, to activate the EMS system in some way or another involved mental health or behavioral health. With that many calls coming into our system, we tried to decide, is there some way in an hour we could teach a first aid class in how to handle the first few minutes of mental health issues until the experts arrived at the scene. If you would, sort of CPR for mental and behavioral health. And we put together this program, the R.E.A.D.Y program, in an effort to try and do exactly that. I'd like to thank the City of Auburn, the mayor, Nancy Backus, who helped to put together this, but mostly I want to thank our heroes in the police department, the fire department, and EMS who respond every day to scenarios at our homes, on our streets, that involve issues around this. Because you see, there are communities in the United States that when the sirens and the flashing lights show up, they're not necessarily viewed as the heroes. People end up getting tased. People end up getting shot, partly because they're not sure what to expect. What we're hoping in this hour is we can help train you what to expect when you call 911, how to help make the scene safe, and when the experts arrive, what to expect and how to move forward from there. So our course outline today, we're going to talk a little bit about the scope of the issue. How big an issue is behavioral and mental health? We'll talk a lot about communication tips, the things that you need to say, the way to remain calm. We'll talk specifically about some case studies, suicidal individuals, people who are violent, people with odd behavior. We're going to ultimately hear from both our police department and our EMS on what they anticipate the scene to be like when they arrive and what their role is when they get there. We'll recap towards the end 4 important communication tips that I want everybody to remember in one of these scenarios. And we'll finish up by talking about 7 ways that you can take care of yourself to help prevent the development of mental and behavioral health issues. And I think that by the end of this, you'll have a pretty good grasp of how to handle those first 5 minutes until the experts arrive. So the scope of the issue in America today, 1 in 5 people in the United States will have a mental or behavioral health issue over the course of a year, 20%. And over 50% of people in the United States are going to have at least one episode in their lifetime of a mental or behavioral health issue that could possibly benefit from expert care. In 2014 here in Auburn, we generated 486 reports that involved EMS transport to my office for mental and behavioral health issues. In 2015, that number went up to 524. I just finished an entire renovation and build out on my emergency department 4 months ago. I built an entire wing in my emergency department and expanded to 25% of my overall beds are now devoted specifically to mental and behavioral health and substance abuse issues. So when you talk about mental and behavioral health, you need to understand its entire spectrum. The most common thing, over 40 million people in the United States will suffer some form of general anxiety disorder during their time. Now, you have to understand, stress can be a motivator. We all live under those issues of, do I have enough time to get my homework finished? Can I pay my bills at the end of the month? Will I be able to make it to the soccer game and still do the grocery shopping and all the other things I have to do? Stress in some ways motivates us to get things done. But when the stress starts to overwhelm you, and instead of working to stimulate you to get things done, it gets in the way of getting things done, and it starts to take over your entire thought process, that's an anxiety disorder. And when it rules the day, it's probably time to have help in addressing that. Now, there are certain people that overwhelmed by these issues, and they get true panic attacks. Panic attacks are episodic, but they're overwhelming and they have real physical manifestations when they happen. People can feel their heart rate speeding up. They can feel the heart pounding in their chest. They get real shortness of breath. They start to get numb and tingling in their lips, their hands, their feet. These are real visceral manifestations of their panic attacks. And until you recognize that it is motivated by anxiety, it's really hard sometimes to get out of that spiral of having it get worse and worse in a vicious cycle. And there are some people that have anxiety disorders that are triggered by a specific incident in their life. They may be overwhelming things that you understand and can relate to the fact of a death in the family, being witness to an overwhelming thing such as an automobile accident with a death. It can be a rape. It can be other things that lead to what we call a post-traumatic stress disorder. Understanding that there is a trigger point that brought this all about helps in the counseling and these individuals. This is particularly common in our veterans who are now involved with their care all over the United States. PTSD, as we call it, is something that we really need to address specifically about the incident that brought it on in order to help people move forward. Secondly, among common things in the mental and behavioral health are going to be substance abuse and how it plays into major depression. And it's really hard in a lot of these situations in America today to separate out those two. 1 in 7 Americans right now will use a medication in a non-prescribed fashion in the next year. That's pretty overwhelming. And when you stop to think that the number one cause of accidental death in America today is overdosing on drugs, particularly opiates. Opiates are an epidemic in America today. And when you start down that process of becoming addicted, you may present in a number of different places, but you're probably going to end up on my gurney in the emergency department, either because you've overdosed, because you're looking for a way out and are looking for help to withdraw and detox, or you've run out of your pills too soon, or you've run out of your substance too soon, and you're looking for a way either to try and get more, which may not be the right answer in the emergency department, or a way to find something else to help you bridge the process so that ultimately you can be successful. When you start to become addicted, it starts to alienate you from your family, from your friends, It can be loss of your employment, and all of these can spiral into that inevitable process of addiction that leads to depression. You should understand that when you truly end up becoming addicted to opiates, and I mean true addiction, it's no longer about waking up every morning and trying to figure out how to get high. Once you're truly addicted, you wake up every morning trying to figure out how to avoid the low. You don't want to go through withdrawal. And so part of our focus moving forward when it comes to opioids and other addictive substances is to try and figure out how to bridge that overwhelming physical and mental dependence that you go through with withdrawal. It involves counseling. There are now medications out there that can help. Things like buprenorphine, naltrexone. You may have heard of them under other names as well. There's also an amazing drug out there right now for the overdose patient that can actually take someone who is in the process of actively dying and reverse the opiate and save them. Something called naloxone, which here in Auburn we've made a huge effort to put into our police response vehicles. We're trying to get it over the counter to as many different individuals as we can, because when someone's truly overdosed and they could die in the next several minutes, we don't want the heroes to have to wait to get to my department to get a drug that, if it's at the scene, might save somebody right away. And when I have that wonderful window of having saved someone from an overdose, it's a great time to talk and to begin the conversation of, how do I get out of this spiral? Because the spiral of addiction will frequently lead to major depression. Feelings of sadness. One starts to lose interest in those things that used to make a huge difference in their lives. They no longer want to ski. They no longer want to go to their children's basketball games. And they start losing touch with those people that they were involved with who meant so much to them. They may be very tired. They may sleep inordinate amount of times, but they may have a sleep disturbance where they stay awake all night, worrying and depressed, only to sleep other times during the day. It's interesting because most of us think of depression as a withdrawal, but early in the process, there can be anxiety and agitation as people start to realize in some fashion that they're becoming depressed. It's not a good feeling, and people don't want to go down that road. So they'll oftentimes, early in the process, be anxious, trying to get out of situations more and more frequently, agitated if confronted about their depression. But in my job, when you come to the emergency department, there's a critical time period where we try to decide, are you depressed, or have you really gone beyond the process of depression to suicidal? When you start to actively have thoughts about how you might die, or when you get to that point where you start planning the process of how you might die, that's a huge swing that we try to make a big differentiation in the emergency departments. And I think that at home, when people start talking about things like suicide, that's a moment that has to come up to everyone's radar as it's time for professional help. We'll also talk a little bit today about schizophrenia and bipolar disease. These are real biochemical abnormalities in the brain that prevent the individual that suffers from this from sometimes grasping the reality of their situation, and clearly can offer huge hurdles in getting out of the spiral that goes down. These truly respond in some instances to medications, and finding the proper medication is important. Bipolar, which is manic depression, is exactly that. It swings from highs to lows. And bipolar tends to be a swing from high to low over longer periods of time, over days, weeks, months. People may have times where they are amazingly efficient, They stay awake for hours at a time, being driven by their mania to get things done. In fact, some very famous people in history in the United States, people like Ted Turner, who founded CNN and won the America's Cup, was bipolar and would do amazing things when he was in his manic phase. Some of us have heard of Edgar Allan Poe, an amazing author in American history. So you can accomplish tremendous things in the manic stage, primarily if you're in what we call the hypomanic stage, just below true mania. But when you get to true mania, you can actually feel invincible. You can actually do things that are not in your best interest. You start to do things that can alienate people because you're a superhero and you don't necessarily care as much at that point. Those true manic episodes can be a danger in the fact that you may do risky behavior that can result in injuries and death. You can also get easily frustrated and angry at that top of the manic phase. But you can also dive low. You go into the depressed stage. People drop off the map, sometimes for days, weeks, months at a time. Ted Turner used to go on vacation for a while during those episodes. The profound depression in a manic depression swing can easily get to the stage of thinking about suicide and other options on how to escape from where you are because you don't really realize any other way out of that spiral. It's important when we deal with manic depression to recognize that the goal is not necessarily to stop the swings, but to level them out, to keep people from getting too high or too low. People still want to have great days, and they still are recognize that there may be days that aren't perfect, but it's avoiding those huge highs and huge lows, and that's what some medications can do. Then we talk about schizophrenia. Schizophrenia can be a wild minute-to-minute swings in people's behavior and reality. People with schizophrenia have true biochemical abnormalities in their brain that make grasping what's real and what isn't real difficult, if not impossible, for them. They can get to the point where they hear voices. They can see things happening that aren't truly there. And they sometimes have great difficulty at understanding what is real and what isn't real. Keeping the communication lines open with these people is imperative, getting them to grasp what is reality and what isn't reality. Medications help in this regard, and keeping people on their medications is really important. But these are the people that sometimes you might pass on the street who are pushing their shopping carts outside the 7-Eleven, who are talking wild, sort of flamboyant speech that involves religious ideas or could be talking about space aliens, all sorts of things because they don't grasp that. But it could also be very subtle. People just withdrawing because a voice inside of them is telling them to hurt themselves or to hurt others. What I want you to understand is that lack of reality base can swing quickly in schizophrenia, whereas in bipolar, it tends to be a more gradual process. Treatment for all of these is in itself its own lecture, but what I want you to understand is that it oftentimes needs professional help. Isolation is the enemy. That's one of the things I want you to come away with today. We need to open up the communication lines. When people withdraw from society, they have increased risks for deteriorating to suicide, etc. Communication is the key. There are new forms of counseling that involve group therapy, other modalities where people communicate and learn to find friends, learn to find solutions to move forward. There are medications, and as we talked about, in anxiety, it may be sporadic medications that you only use at the time that you're starting to have physical symptoms to help decrease that fast heart rate, to help decrease that isolated panic attack before it gets out of hand. As we said, bipolar disease is more along the lines of trying to flatten the curve of the swings. And schizophrenia is really at the neuronal level to try and help grasp reality and keep yourself focused to avoid those hallucinations and other thoughts. Finally, there's cognitive behavioral therapy that's used frequently, where we give people feedback to how their mental and behavioral health is being viewed by their outside environment and friends, and how that directly affects them. So if they realize that by keeping these in check, by staying on their medications, their life is moving in positive direction, they're still having their friendships. Those are sort of behavioral positives, but also teaching people to recognize that when they get off their medications and things spin out of control, it becomes harder to hold down their job. It becomes harder to maintain their relationships with their family and their loved ones, and that they want to, from positive feedback, work towards solutions. Let's go back for a second and talk a little bit about the scope of the problem. In King County, the Auburn area, in 2012, 11% of Auburn residents on a poll said that 14 or more of their days in the last month were bad mental health days. Half your days were bad, 1 out of every 10 people. Let me make it even more pointed in that 5 years later, when we redid the study in 2016, it was up to 17%. Almost 1 in 5 people said that half their days were bad mental health days. This is clearly something that's impacting. Look down the road of the person next to you if you're watching this as a group, or think through your circle of closest friends. 1 in every 5? So now comes the CPR part. I want to teach you how to manage with a few simple tools that first few minutes in a mental health crisis, how to recognize it, how to realize when 911 might be the proper avenue for you to take, and how to keep the scene safe until the experts arrive. Safety first. Communication tips are, if someone's at risk, we want 1 person at risk. We don't want 2 people at risk, 3 people at risk, the entire classroom at risk. We only want 1 person at risk, and we want to make sure that they understand we're there to help them. So if you come across somebody that you think is at risk, first question is, are you alone? Is it just the 2 of you? Because if it is, that may not be the safest situation, and you might need to call for help. Other people around you. In my hospital, I have what's called code gray. If you hear overhead code gray, it means wherever you're at, people should come and respond and be around you, so that the individual who may be offering threats to themselves or others recognize that there's lots of people around that want to help. Is that person at risk of falling or immediate injury to themselves? When we talk about the elderly and we go into the concepts of depression related to dementia, these people are frequently at risk to falling and harming themselves. When we talk about substance abuse, people that are intoxicated from alcohol or other drugs, they may be at risk at falling and injuring themselves. And depending on their scenario, if they're standing on the edge of the bridge, the fall may be real significant. So getting people into a safer situation where they're not at risk to harming themselves or falling is a big deal. I give this lecture at a mall nearby our hospital in town, and we talk about if you find somebody curled up in a back hallway at the mall, getting them out into a safer situation may be a reasonable thing, but if they happen to come across them in the middle of the central food court, that may not be the best place for them either. Trying to find them a safe place where they don't feel threatened and you can talk to them in a quiet, one-on-one situation is a good thing, but with other people where they can visualize what's going on. So steer to a safe environment. And finally, is there a weapon that's visible? We only want one person that could be at risk. We don't want 2 or 3. Police really gear in on firearms because right now, when we talk about gun violence, recognize that well over 60 or 70% of individuals that are injured by a firearm, it's self-inflicted. They've shot themselves. So we worry about suicide when you put a firearm because it only takes one pull to make a significant difference. But I want you to remember that anything can be a weapon, particularly if it can be picked up and thrown or wielded in any fashion. So when you look around a scene to make sure that the scene is safe, we look for things like brooms, mops, rolling pins, things that can be swung. We look for scissors. Anything that can be used as a weapon, try and make sure that those are away from the scene when you're coming upon that and trying to make the scene safe. Next, you need to have an exit plan if things get scary for you and you don't feel safe. So, we teach people if you go into an emergency department room like I do to talk to someone who's there for a mental health issue, patient you door. Never let the patient get between you and the exit. You need to have a safe way of getting out of the situation. You should stay near and close to the person so that they understand that you're communicating with them, that you're interacting with them. But there should be enough space early on so that they can't swing and harm you. I've been knocked unconscious by a 6'4" schizophrenic who I didn't realize how long his arms actually were. So now I have a mental space that I understand how close I can be, where I can look people in the eyes and I can talk to them, but that they can't swing and make contact with me. Along those lines, touch is a healing process. A shoulder or a hand on a shoulder can be reassuring. But if it's not invited, it can also be a threat to people that are feeling very scared and very worried. So early on, only touch a patient or someone that's in mental health crisis if you're invited into that, or if you're asked to do that, or if you ask permission and are given permission. Because I want to reiterate, people can react quickly if they're touched and they don't want to be. My personal experience, I offer a hand to everybody as a handshake when I walk into a room in those situations. The handshake is thousands of years old. It was initially offered as showing that there was no weapon in your dominant hand. And in some ways, that's still an offer today. This is safe. I'm here to help you. Finally, if you get a bad feeling, figure out a way to excuse yourself from the situation. I frequently will say, hey, listen, I'm busy right now in another room. I got to go check on that patient real quick. I'll be right back. If you're dealing with a situation at home and you think you need to call 911 to get somebody there, you might just say, hey, listen, I left something on the stove. Hey, I got to go to the bathroom. I'll be back in 1 minute. Don't run away. I'm here to help. Give yourself an excuse to step out for a second. And in a situation where things may escalate, where violence could be a possibility, have a code word to get you out of there. In the emergency department, I'll sometimes tell the clerks, I'll say, if I'm not out of that room in 5 minutes, I want you to overhead page me that I need to be in a different room. Or I might tell my staff, if you hear me use the word white 3 times in a couple of sentences right in a row, it means I need help. Come in the room right then. And I might say, hey, listen, I got up this morning to put on my white hat to come to work and be a hero. I walk into this room, you're sitting here on these white sheets in this white sterile room, and I'm thinking that maybe this doesn't feel real comfortable to you. There, I've used the word white 3 times, and all of a sudden, people in the background start to move forward because they realize I'm not feeling comfortable with this situation. If you call 911, they're going to ask you your location. They're going to say, what's your address? Where do we need to respond to? But location is more than just the address. You should really tell 911, I'm upstairs in the back bedroom on the right in the bathroom. Let them know what part of the scene is safe. Let them know where to focus their attention to getting to the problem right away. The more specific you can be on your location, the quicker somebody can be there in a safe fashion to help you. Maybe one of the most important things I can try to emphasize today is speech needs to be slow, simple, easy to understand, short sentences. Sometimes I get real scientific when I'm trying to explain things, and I'll start saying things like, you're clearly going through a psychiatric decompensation that's triggered by your amygdala, which is not compensating adequately because of your lack of proper control on your anti-epileptic medications. Yeah, I've lost everybody. If I just say, this doesn't feel real comfortable to either of us, let's figure out how we can make you feel better. Easy words, not doctor speak, but things that are easy to comprehend and repeated over and over and over. And now the most important thing I'm going to say in this entire talk, you can't say the word safe enough. I walk into the rooms of every person that I examine, and what I try to teach people in this class is, my opening sentence is, we're here to make sure you're safe. But I need to be sure that I'm safe, and we need to make sure everyone else in this room or in this environment is safe. So let's concentrate on how to make you feel safe so that everyone else can feel safe too. And I may say that 3 or 4 times in the first 5 minutes that I'm in that room. Because repetition helps. Repetition helps particularly in people that are having problems with reality, people with dementia, people that may be substance abuse and intoxicated. Slow, easy, repetitive, and the word safe. But you should understand that body language does a lot too. If I'm sitting and I'm talking to people and you can see me with the frown and my arms crossed, it's not necessarily engaging or warm and friendly. And let me tell you, if I pull my finger out and I start pointing it, that doesn't diffuse the situation. If I point my taser, if I point my gun and I say stop or I'm going to use this, that doesn't usually calm the situation. Crossed legs, jiggling feet and legs, like I said, pointing directly in their eyes, those are non-relaxing, non-comforting. Now, they may make you think that you're trying to make the scene safe, but the goal is to diffuse and to calm the situation down. So what you should do is you should smile. You should try your best to make eye contact as much as you can. This is about communication. Nod when they speak. Let them know that you're hearing what they say and you're acknowledging it. Sitting back in a chair or gently leaning forward towards them are fine. Those show a relaxed situation and one that's wanting to bond. But if you're leaning forward towards them, or if you're sitting next to them on a gurney or on a chair, understand that that can be invading their space, and you better be sure that there's a safe distance. But I can't say it enough. Isolation is the enemy, and opening communication is the key. Opening communication means it's a two-way talk. It's a two-way street and a two-way communication. This is not about you walking in and lecturing somebody on how this is going to go down. This is about trying to listen to them and hear what they have to say and what's bothering them. And I will frequently try to pick up on the recurrent theme. This is all about me not getting along with my mom. This is all about me having problems with my boyfriend. I try to listen to those themes and I try to play on those themes because it says I'm listening to what's really bothering you right now. That said, I try to steer it in a positive fashion. I don't try to listen and repeat negative things. I try to spin it in a positive fashion. So it sounds like you're really upset by that individual. No, I don't think the right answer is how can you harm them. I think the right answer is let's figure out how to open up those communications and decrease this anxiety and this anger between you. Now, the suicide individual, that's a very special case. Remember, I told you that when somebody crosses that point where they've actually started to think about how they might die or planning it out, taking too many pills, jumping off a bridge, using a firearm, that's the time that it needs to go to a professional situation. Those people will frequently start feeling hopeless, like there's no way out of the spiral that they're in. They feel trapped. They feel as though they're a burden to other people and that the world would be a better place if they weren't in it. They may make comments about death and dying, or they may start exhibiting reckless behavior. They're the ones that jump up on the railing of the bridge and walk along it. They might flippantly hold a firearm in what looks like a careless fashion with the safety off. Reckless behavior can be a sign that I'm one step away from doing the next thing to harm myself. There may be direct threats to harm themselves. There may be direct threats to harm others. But it could be even more subtle, particularly in the elderly, where dementia plays into this, where they start to give away all their prized possessions. The things that they said, I would never part with this. My mother gave this to me. This will be with me for the rest of my life. And then all of a sudden you find out that, oh yeah, I gave that to the postman because he's a nice postman. I gave that to my granddaughter because I don't really need it anymore. So be aware of that. People look like they're trying to organize their life for it to end. It's one thing if we're talking hospice. It's another thing if we're talking somebody that's starting to become suicidal. The last thing I want to say is gestures are real early in the process. So when somebody cuts themselves, we know what cutters are. Early in the process, that's a very real, very serious situation and sign. Now, if someone's been cutting for years and never harmed themselves, we might not escalate the situation as quickly as an early 12-year-old girl who's telling you she's doing it for stress. Just recognize that that may be the first step along the lines towards ultimately utilizing a weapon on themselves for more serious things. And it's really important to understand where substance abuse and particularly alcohol falls into the mental health situation with suicide. 90% of people that successfully commit suicide have a previous mental health disorder. So we know who the at-risk populations are. The other thing to understand is that substance abuse does two things. Number one, it causes an increase long-term in depression. It gives you this scenario that you're trapped, you can't get out of that situation. But it also lowers the threshold for doing the actual act. People are more likely to commit the suicidal act if they're intoxicated, if they're drunk. They might jump off the bridge more likely if they're drunk. So frequently sobering people up and giving them a window to the fact that they might be able to become sober individuals again is a first step that's critical, but it's a real high warning sign when somebody's actively intoxicated. Now we talk about high-risk groups. I want you to understand that mental health disorders, behavioral health disorders, span the entire gamut. They go from early childhood all the way up to elderly with dementia. Economics are no prevention of mental health issues, but we know that there are certain higher risk groups: Native American, Alaskan youth, youth in foster care, individuals who have previously cut or self-harmed, anybody with a previous history of a suicidal attempt, or anybody with a serious medical issue. When people have problems like cancer and they don't think that they have the chance of curing it or getting over it, people have diabetes that they haven't learned how to control, people that have long-term physical illnesses are at higher risk to become depressed. We know veterans have a higher risk of PTSD, depression, and other mental health issues. We know the LGBTQ community also can feel ostracized and start to develop this. We also know that men in midlife crisis and older white males have a higher incidence of firearm suicide. And so even though these are high-risk groups, the only reason I want you to understand high-risk groups is we frequently put our efforts and our economics into trying to help those particular groups. It's not that anybody else doesn't matter or that we don't want to be on guard for everyone, but you just have to understand we sometimes throw community resources to these groups because we know they're higher risk. Step one is to ask someone if they're at risk. It's okay to say, are you feeling depressed? Are you feeling like you don't see a way out of this? I have to ask the specific question, are you suicidal? What I want you to understand is if the answer is yes, you never, ever agree to keep the plan secret. What we've all heard the story of is the two 14-year-old girls texting one another, or on social media, somebody putting out a tweet that says, there's no real reason to go on. I think I'm going to end it, but don't tell anybody. Or the classic email that says, don't tell my mom we're having this conversation. That's not right. We don't keep these conversations quiet. We don't keep them to ourselves, and we don't agree to keep this secret. This is when you need to contact professional help. It can be 911. It can be a crisis line in your neighborhood that you call. So you should know what those lines are. The individual with odd behavior. The elderly individual sitting in the middle of their driveway at 2 o'clock in the morning in their pajamas. The homeless woman pushing the shopping cart, talking to herself quite loud outside the convenience store. These can be signs of mental health illness, but they don't necessarily mean crisis, but they probably mean that we need to open those lines of communication. I'll frequently stop and ask the person with a shopping cart, hey, you need any help? And you'll hear from the police a little bit about the fact that talking to the telephone pole may not be bad, but we have to be on alert for who's at risk. Particularly people with dementia who are acting confused and fearful. And frequently you have to repeat over and over and over to those individuals that they're in a safe environment and that you're here to help. You may have to continue to identify yourself over and over again. I'm your daughter. I'm here to help, Mom. I'm the doc. I want to help. I'm the police. I'm actually here to help. We want to calm this situation. You may have to tell who you are over and over. And did I mention that you can never say the word safe enough? Remain calm. You don't want to argue. You don't want to threaten. Identify yourself so they know who you are. Stay alert to threats to others or yourself. Be on alert for weapons and other things along those lines. Offer to call a friend. Offer to call a counselor. This is about opening communications, not closing communications. If you feel endangered, that's a reason to call 911. Never hesitate to call 911 if you're worried, if you're frightened. Because people don't necessarily end up in jail or injured with a 911 call. It should be a hero that shows up, but you can diffuse the situation to help make it calmer when the experts arrive. What I want you to understand is we're going to hear a little bit from EMS and police about what they do when they arrive on the scenes. But I do want you to understand they want to be a hero. They go through education to learn how to come onto the scene and help protect others. That because police are there doesn't mean you're arrested, but police have priorities. Number one priority is to make sure that everyone on the scene is safe. That includes the patient, but it also includes others around. They also are obliged to try and protect property. If things are being destroyed, they might have to step in. They might have to put someone in handcuffs to calm the scene at the moment. But their first obligation is not to the property. Their first obligation is to the people to make sure they're safe. And with that, I'd like to have my police officer and my EMS talk a little to you about what they do when they come upon the scene.
Thank you, Dr. Anderson. My name is Dan O'Neill. I'm a commander of the Auburn Police Department. I'm going to start off my presentation today by giving you a little background on the training that we go through when it comes to dealing with individuals experiencing crisis. Currently, 25% of all patrol officers that are assigned to work the streets are required to attend a 40-hour crisis intervention training class. Here at the Auburn Police Department, we exceed those expectations by sending every commissioned officer that's responding to calls for service to the 40-hour crisis intervention training class. And then in addition to that, starting in July of 2017, every commissioned officer will be required to go through a 2-hour crisis intervention training refresher class. The police respond to a variety of calls that are linked to crisis intervention. And we get these calls either because the individual who's experiencing crisis calls, a friend or relative calls, or somebody calls from the crisis line or their counselor calls and request that the police respond and intervene with what's going on. There's basically 4 different types of calls that the police are going to respond to and assess an individual who's experiencing a crisis. The most common type of call is an individual who's just engaged in abnormal behavior. We respond to quite a few calls that are of this nature, and a common example would be an individual talking to a telephone pole. We're going to show up and make contact with an individual who's talking to a pole, and a lot of times we know who this person is and they know who we are. And when we talk to them, they're going to be aware of what's going on. They're going to let us know that, yeah, they're aware of the fact that they're talking to a telephone pole. They're going to tell us their condition, and they're going to tell us what kind of medication they're taking. And a lot of times they're going to let us know that they haven't been taking their medication, or they just need to get in and talk to their counselor because their medication's no longer working for them. Well, in a situation like that, this person's not a threat to themselves. They're not a threat to anybody else. It's not against the law to talk to a telephone pole. It's just unusual. So in a case like that, we're going to make sure they're okay, they're aware of what's going on, and that they're going to get some help, and we're going to end our contact and send them on their way. The second most common type of call that we're going to respond to is an individual who's destroying property. The first thing we're going to do when we get there is get the individual to stop destroying property, have them talk to us, make sure that there's nobody else near them that could be injured or become involved in the situation. And then we're going to talk to them and go through the same process, find out what's going on, see if they know what their condition is, see if they're taking their medication or if they're overdue to see their counselor. And once we get all that information, we're going to do what we can to get them some help and either get them in touch with their counselor or get them to a hospital where they can get treated. Now, unfortunately, it is a crime to destroy property, but our primary focus here isn't to arrest the individual for destroying property. Our primary focus is to get them help, make sure they're safe, make sure others around them are safe. In some cases, though, we will be required to write a report and forward it to the prosecutor's office, and they could face criminal charges. But a lot of times, the courts will look at these cases and they recognize that it's more important for the individual to get help, that it really wasn't their intent to destroy some property. They were doing this because of a condition that they're experiencing. So a lot of times, the courts will use that to force them to get some help and treat their issues. A third type of call that we respond to is when a person is a threat to themselves. A lot of times we'll get a call from a friend or a relative or even an individual that'll say they're just not having a good day and they feel like hurting themselves. In a case like that, we'll find out if they have taken any steps to hurt themselves. We'll remove them from an area where there might be weapons or other things that they could hurt us or themselves. And then we'll assess them further and get them some help. A lot of times they'll voluntarily go to the hospital, so we'll call for an ambulance and have them transported. Or sometimes if they won't go voluntarily, then we have the authority to involve them, which means we force them to go to the hospital and get some help. And then the fourth type of call that we respond to, and this is probably the most dangerous type, is an individual who's armed with a weapon that's threatening themselves or others. This is a person that's suicidal with a gun or suicidal with a knife, or they've already used a knife to injure themselves. What we're going to do in a situation like this is we're going to get there. First thing we're going to do is make sure everybody around them is safe. So if there's other people in an apartment or other family members inside the house, we're going to get them out of the house and get them to a place of safety. And then we're going to communicate with this individual and talk to them about what's going on. We're going to try and get them to put down that weapon and come outside to us. We're not really going to make it a priority to go inside that house and get them. We're going to give them time to de-escalate, put down their weapon and come out and talk to us. And then we're going to let them know that they're going to be put in handcuffs so that that doesn't alarm them and re-escalate the situation. We're going to put them in handcuffs for our safety and their safety. And then this is going to be a mandatory involve. They're not going to get the option to voluntarily go to the hospital. It's going to be a mandatory involve where they're going to have to go to the hospital and talk to a mental health counselor or talk to somebody like Dr. Anderson. Once we have the person out of the house and the situation is safe, then we're going to turn it over to the Valley Regional Fire Authority, who's going to provide immediate first aid if they're injured, or they're going to help make arrangements to get that person transported to the hospital.
I'm Kelly Hawks, and I'm with the Valley Regional Fire Authority. So much like the police department, our firefighters get extensive training on working with people that are having a mental health crisis. About 80% of our calls are medical aid calls, and a significant number of those are calls for people who are in crisis. Our job is to work with the police department on these calls. We serve as the liaison between police and the emergency department. So once we arrive on scene and police has determined that it's safe for us to go in and assess the patient, we go in, we talk to the patient, we take their vital signs just to see where they're at, and we might talk to family members that are there to see what information they can give us. And then we'll determine if that person needs to be transported to the hospital. If they do, we can either transport them, we can use a private ambulance company, and sometimes for the safety of the patient, the transport might involve using soft restraints. So after the person leaves the hospital and they return home, we have a program that we are able to follow up with the family and the individual just to find out how they're doing after the incident. These type of situations can be very overwhelming for everybody involved. So we're able to help the families connect with resources in the community and information. We can help arrange rides to and from appointments. And really the goal is just to help the families, the individual involved, take control of their lives.
So I want to try to finish out by saying that mental health and behavioral health issues are a huge illness spectrum in America today. It's a spectrum. People can have only anxiety, only depression, only substance abuse, only schizophrenia, but they can also have any combination across that entire gap or that entire spectrum. And it's important for us as a community to look and see what we offer as resources in our community. We may need to expand our emergency departments. We may need to find more shelters. We may need to find more counseling opportunities. But it's imperative, and I'm asking you, if you're watching this, to try and put together a list of what resources exist in your community and try to make an effort to push to expand those to help this. And so I want to come back to the 4 communication tips I want to leave you with today. Safety first. Make sure that the patient remains safe, that you remain safe, and that everyone else that could come in contact is safe. Number 2, keep the speech simple, short, easy to understand, and repeat it often, over and over again. Body language says a lot, remember? So, a smile, leaning forward, and staying engaged with good eye contact is critical. And it's communication. It's as much listening as it is speaking. So open your ears, but open your hearts to this group because they clearly need our help to keep the situation safe. And on that lines, how do you keep yourself healthy and safe? I offer a couple things for you to take home and review. Number one, obviously, I'm a doctor. Eat healthy, exercise, stay well rested, engage in your community, but mostly value yourself. I'm training you to be a hero in your community. Be proud of that. Get involved with people. Do things in your community that make the community a better place. Yeah, avoid bad habits. You shouldn't smoke. You shouldn't drink in excess. Don't do bad drugs. But also make sure that other people follow your lead. Connect with others. The communication and being engaged is what it's all about. In mental health, isolation is the enemy. And learn how to deal with stress. Maybe it's taking your dog for a walk. Maybe it's doing yoga. Maybe it's taking a nap or doing something else, but find out how to make yourself whole. And volunteer somewhere. Anytime you make the world a better place, you make yourself a better person, and it helps make everything better. We're very open in Auburn to trying to help make the world a better place. While we try to make ourselves better, we're happy to take questions in any fashion that we can to help. Thank you very much for your time.